Okay, guys, thank you for attending in such a short notice. So I was tasked to present about SVT management. These are my platforms for everyone to look at. So I'll start with case. So this is case one. So this is an 8 years old presented with palpitations. As you can see, obviously he has a rapid heartbeat, around 180 beats per minute. Obviously, when you encounter a patient with tachycardia, you want to, first of all, ask yourself, is it narrow complex tachycardia or wide complex tachycardia? Okay. And then in this case, obviously, it's a narrow complex tachycardia. Thereafter, you want to ask yourself, you have two main differential. Okay. So one differential would be, of course, sinus tachycardia, and then another differential would be supraventricular tachycardia. So it's very simple, and two differentials, okay? Is it? So in order to tell them apart or to differentiate between both, in order to determine its sinus tachycardia, obviously you should see normal P wave axis that is monomorphic, okay? And for an SV, and if you think it's SVT, you should not be able to see normal P wave axis, or you may not even see a distinct P wave, or the P wave is polymorphic or abnormal, of course, in axis. Okay, so either abnormal P wave axis, difficult to see, cannot really see P wave, or polymorphic P waves. Okay, makes sense, guys? Okay, if it's really easy,
Yes.
whenever you see tachycardia that is narrow, immediately you study the P waves. Okay, so in this case, obviously, there is no. Do you guys see any P waves that you can? يعني distinctly recognize. I can go
No.
back. Sorry. So this is the same ECG, guys, okay? So there's no P wave, right? That you can see, right?
Yes. Yes.
QRS, T, nothing really, QRS, T. Okay, so it's more likely SVT. Furthermore, طبعا this is an example of sinus tachycardia. So this is a 14 years old who is leukemic, febrile, with the heart rate of roughly 150, 160 beats per minute. As you can see, there is a P wave that is positive in lead 1, okay, and lead V6, okay. Remember, the sinus node starts here or originates here, and the axis of the P wave should be towards the left and inferior, okay. Left meaning lead 1 and V6, so P wave should be positive in the left leads because it's going towards the left leads in lead 1, for example, and V6, and should be positive in the inferior leads, such as 2, 3, and AVF. Okay, so in this case, there's a PQRS tachycardia and the P with one-to-one relationship, and the P looks like it's coming from sinus in origin. Okay, furthermore, sinus rate often should be 220 minus the patient age. It is usually secondary to something, for example, in this case, fever. Okay. It is often the rate is not fixed, and there's a gradual increase in heart rate and then gradual decrease in heart rate with 1-to-1 PQRS ratio. Okay. Um, so, so in this back to the initial case, like we said, it's most likely the ECG is suggestive more of an SVT. And remember, the patient was sitting in clinic, not doing much. Okay, and then thereafter, you ask yourself, is it regular or irregular? Okay, if it's regular, your differential is a little bit different than if it was irregular. Okay, so in this case, it was obviously regular narrow complex tachycardia. Okay, so now we had seen a case that is regular narrow complex, not sinus tachycardia, which equals to SVT. And then next thing is it stable or unstable? Most of the time the patient should be stable, especially if has a normal heart, normal function, healthy individual. Often everyone would tolerate SVT. Okay, so if it's stable, then you want to, of course, treat the ESVT with vagal maneuvers, or adenosine, or if you have a patient with atrial pacing ability, for example, post-operative patient or patient with pacemaker, or if you have or you can insert like transesophageal lead that can capture or pace the left atrium. You can try to rapid atrial pace to terminate the tachycardia. Okay, obviously, most commonly people do vagal or adenosine, and then you have to record the ECG response during your vagal or adenosine administration. Okay, and obviously, if the patient is unstable, you should just shock the patient and make him stable. Okay, make sense, guys?
Yes.
Okay,
Yes.
should be easy. Okay, insane. So, vagal of obviously depending on the age, very young patient, ice immersion, gastric tube insertion. All the patients can perform Valsalva maneuvers or headstand. Okay, and then with adenosine, you want to insert a large bore, big flush, three-way stopcock with a good dose. So, if I know most people would start at 0.1 milligram per kilo or 100 mics per kilo, but I would suggest start with 0.2 or 0.15. 0.1 is very wimpy dose. Okay, so start a little bit higher, or at least start low. But if nothing happens, go. Always try a higher dose. Okay, at least 0.3 per kilo. Okay, before determining its adenosine failure. Okay. So I would always aim for a higher adenosine dose. And then, but mind you, you should avoid giving adenosine in irregular rhythm. The rhythm should be regular, okay? Even for white complex rhythms, if it's regular, patient stable, you can still give adenosine. But anything irregular, I would not give adenosine unless you consult with someone with more experience, okay? So remember, with vagal or adenosine, it could be diagnostic. For example, this patient is having tachycardia. Okay, you give adenosine, and what do you guys see post adenosine?
Again.
What do you guys see post?
Uh, like a flutter wave.
Right? So yeah,
Mm.
so with adenosine, you unmask the flutter waves. Okay, so this was an atrial flutter that you may not be able to appreciate.
Mm.
But with adenosine, it doesn't terminate the flutter, it just slows the QRSs so that you can see the flutter waves. Okay, so sometimes adenosine is diagnostic, meaning you figure out that the patient has flutter post adenosine administration, or with adenosine, it could be therapeutic. Of course, like in this case, you know, narrow complex regular tachycardia, give adenosine, and then it terminates. Okay. Okay. So this is an example, an ECG example of a patient who has tachycardia, narrow complex regular. Patient is post-operative. Someone did rapid atrial pacing, and then the tachycardia terminates. Okay. So these are all maneuvers that you could do to acutely terminate the SVT. Okay. This is not our ECG, it's an ECG given to me by my friend Dr. Said. Okay, it's a nice example I thought you should see. Okay, so this is called rapid atrial pacing. So like we said, this option is available when you have a postoperative wires connected to the patient, or the patient has intrinsic pacemaker, or there are leads that go through the esophagus that could capture the left atrium that we don't routinely use, okay? But for this purpose, okay? Okay, so obviously when the patient is unstable, like we said, we can shock the patient, and then shockable rhythms, remember, we're talking about SVT only, okay? Shockable rhythms are reentrant rhythms which are characterized by sudden onset and termination. They are often regular, and classic examples are flutter, atrial flutter, AVRT, or AVNRT, okay? So flutter is a circuit, re-entry circuit in the atrium. AVNRT is a circuit, AV circuit in the AV node. AVRT is a circuit using the AV node and up through an accessory pathway, and so forth. Okay. Also, obviously, atrial fibrillation is shockable. We don't usually see atrial fibrillation in pediatrics as much, but of course, the adults do see atrial fibrillation all the time. And then when you want to shock the patient, obviously use pads. The pad's best positioned in the anterior posterior location of the chest for atrial arrhythmias because you want the shock vector to be hugging the atria. So anterior posterior position, like in this case, so anterior chest pad and posterior chest pad, the vector would go directly through the atrium. This is best for atrial arrhythmias, AFib or flutter. And if you have just a regular SVT, you can otherwise do the anterior lateral pads position. Okay. Um, so back to management. So for SVT that is regular, like we said, you give adenosine, you do vagal, or so forth. And then if the SVT terminates, but then reinitiates, you know that you diagnose an SVT that is reentrant with adenosine with AV node that is part of the circuit. Um, but you know that it comes back. So then you want to give medication so that next time you give adenosine, perhaps it will stop for good. Okay, but you want to help the patient by administering IV usually medication because you want fast acting medications. So what I usually do if the function is depressed, I usually start with amio, plus minus ditch maybe, but mainly amiodarone. But if the function is normal, we can do esmolol, plus minus if things are not, easily terminated, plus minus other oral agent, okay? But our IV options that we have in Kuwait, amiodarone or esmolol are your main IV options, okay? Um, but if you give adenosine, there is good technique, but there's definite no response, then you should probably consider other diagnosis, okay? Or wrong technique or inappropriate dose, and so forth. Okay, makes sense, guys? This is why sometimes I ask
Yes.
for you guys we need a quick function check. Uh, you know, Obviously, if the patient just presented for the first time, we want to make sure there's no congenital heart disease, for example, Epstein or anything else. Okay, heterotaxy, Epstein, or anything else. Okay. Okay, so what are the doses? People ask me about the doses all the time. For amio, preferably central line, and then people can usually bolus and then may start an infusion. Okay, I honestly don't bolus all the time, especially babies, because they might be very sensitive to amio. So if the patient is relatively stable, I start with infusion and skip the bolus. If the patient is a little bit, not a baby, not an infant, especially newborn, outside newborn period, then I might consider bolusing. But again, I think infusion is often good enough. Okay. So for bolus, you want to be slow. And then, you can give 2.5 per kilo up to 5 per kilo, but slow bolus. Okay. I would not suggest rapid bolusing, except if the patient is really sick, almost you want to start CPR, doing very badly, okay? And then you can repeat the boluses. But with the infusion, we usually start 5. We can go up to 15 to 20 microgram per kilo per minute, okay? Um, um, and for verapamil, I give IV verapamil. I don't typically, but this is the dose for IV verapamil. You can do central or peripheral. It's rapid acting and has immediate effects within 3 to 5 minutes. Okay. Esmolol, I do more often. You can do again central or peripheral IV, and then I usually start with 100, but immediately go up to 200, up to 300 if nothing happens, like nothing bad happens during the 100 infusion. Okay, it's very rapid acting, of course. Um, and for DIG, you can do as well central or peripheral IV infusion. The dose of digoxin is complicated. It depends on the age and prematurity of the child, but usually um, you do, in general, the load is 10 mics per kilo. but less if the patient's 10 years and older. And then the repeated doses are half the initial dose, okay? And then then you do maintenance around 5 mics per kilo Q12, okay? Obviously, you have ditch levels that can guide you in terms of doses, okay? There is IV flecainide and sotalol options. We do have IV flecainide. We don't have IV sotalol, but it's available in the United States and elsewhere. So some you might see IV flecainide and IV sotalol that people might use. Okay, for but if you give adenosine or vagal or rapid atrial pacing and the SVD terminates, terminates for good. I mean, it terminates and remained, patient stayed in sinus rhythm. Then usually I admit if the patient is nonverbal, meaning less than 3, 4 years of age, we probably should admit for a day or two. But otherwise, the patient stable is verbal, noted the tachycardia at home, and knows how to, communicate with the parents to let them know that he's tachycardic, then maybe outpatient management is okay. Okay, especially if you're using, just beta blockers. Okay, and then you want to treat the family, how to check for, SVT recurrence at home. Okay. In neonates, we usually treat SVTs for roughly 4 to 6 months. Okay, some people extend therapy up to 12 months, but I usually stop at 6 months. Okay, so so neonatal SVT you treat for 4 to 6 months, and then we gradually wean, and then if there's no recurrence, then we discharge from clinic. Okay. If the SVT is beyond 1 year of age, then the SVT is there to stay, and you probably will not be able to stop the medication. So usually you discuss long-term, options. For example, ablation when the patient is usually 15 kg and above, or medications, or as needed pill in the pocket, meaning whenever he gets SVT he takes his medicine. Usually should be short acting like propranolol, so he takes the propranolol, wait for half an hour, 1 hour, it did not stop, then do Valsalva and vagal maneuvers, and then go to the nearest hospital. Or if the patient decided not to do anything, then obviously it's up to them, especially if there's no WW, then usually it's not life-threatening. Okay, with WW, usually we always try to recommend ablation, okay, depending on the risk characteristic of the WW, but most likely we would recommend ablation. Okay, clear, guys? Am I too
Yes.
well? It's easy. Okay.
Yeah.
Okay. زين. فطبعا you have to remember that calcium channel blockers are contraindicated in infants, so don't give IV, verapamil for a child like less than 1 year of age. And then digoxin and calcium channel blockers are also contraindicated in WPW patients. Okay. Um, so, and yes, some people ask me, this is the first episode of SVT. Would you recommend therapy? I do recommend therapy. And I don't need to wait for a second episode because most often it will come back. Okay. Especially if the patient is, young and cannot communicate with the family in terms of, recurrence. Okay. So yes, first episode, regardless, I do start therapy and I discussed all options and then let the family decide what do they want next. Okay. Okay. So now we gave adenosine, the SVT terminates. We don't have to give IV medications. Instead, you give oral medications. So obviously your first drug of choice is beta blockers. Okay. طبعا general rule is beta blockers you can go as high as the patient tolerates. Okay. بس طبعا routinely we do propranolol 2 to 4 milligrams per kilo per day. Okay. طبعا Q6 if less than 4 months, Q8 if more than 4 months. Okay. Uh, in newborns or preemies, they might be at risk of hypoglycemia. So you want to give a little bit lower dose initially and then make sure glucose is fine. Okay. And atenolol, metoprolol, bisoprolol are given to patients that are, more than roughly 1 year of age because they are less less in the frequency of administration is less. Okay, طبعا Q6 Q8 is very difficult to maintain, so I usually do propranolol in babies, but like if someone is above 1 year of age, I just start atenolol. Okay, طبعا adults they like bisoprolol. Mitwalli and his team, heart failure team, might prefer metoprolol, but anyways, so babies propranolol, elderly people or like more than not babies, I would suggest atenolol. Okay. انزين.
Okay.
طبعا we rarely use amio as an oral agent for chronic use, but طبعا you can, of course, in certain circumstances. So people sometimes load and then give maintenance and then the chronic dose. Okay, but طبعا we rarely do that. You can do digoxin, of course, and ivabradine, which is more an agent for atrial tachycardia rather than yani SVT that is adenosine sensitive. Okay, so ivabradine is rarely used, but it's an option for atrial arrhythmias or inappropriate sinus tachycardia. But our most oral drugs that we start off are beta blockers. Okay, طبعا في other options, for example, flecainide. Um, with flecainide, you do 2 to 6 milligram per kilo per day. I usually stop at 5 per kilo per day. I think above 5 is you're just have running risks of flecainide toxicity, especially that we don't have levels available in Kuwait, but you can do levels like in the US, for example. Usually, I monitor the QRS duration for flecainide because it's sodium channel blocker, and then if there's too much flecainide in your system, the QRS would widen. Okay, so it's a very dangerous drug. Furthermore, if the patient is sick, for example, with gastric upset, I tell the family to stop flecainide transiently. If there is acidosis, any sickness that is significant, you should recommend to the family just stop flecainide during illness. Okay, because levels might go up, and then toxicity might happen, and then toxicity is very often fatal. Okay. طبعا it's renally eliminated. So if there's kidney disease, then you wanna adjust the dose. Sotalol is another oral agent, 2 to 4 milligrams per kilo per day, usually Q8 or Q12 depending on the age. Okay, again it's renally eliminated. And then with sotalol, you want to monitor the QT. Okay, QT might prolong with sotalol. Okay, there is another oral agent that is verapamil. You can do Q8 for frequency or Q12. I don't use it that often, but it's an option that you can use, of course. And then, obviously, whenever you do these big guns, flecainide, sotalol, you probably amio, verapamil, you probably should, the patient should be in proper EP clinic. Okay. Okay. Questions, guys, with medications? Did I miss any medication? I don't think so. These are the medications that we use. Okay.
Yeah.
This is
Okay.
this is the dosages for your guidance, and I usually don't deviate from those. Yani, this whatever I wrote here. This is what my practice. Okay. And then okay. طبعا once in a while so this is another ECG. Let's call it case 2. Um, um, and again, what do you guys see here? Really quick. Yeah, not complicated ECG. So tachycardia, صح? Regular, right?
Yes.
Is it SVT or sinus? You see the P waves, okay? Do you think there's any sinus P waves or you don't think so? Like we said, look at lead 1, look at lead 2, 3, and AVF. Do you see P waves that are upright?
Looks like B wave is there. Small B wave.
Yeah, but like upright or not normal P waves?
It's,
Don't look here, V1. Samir, don't look at V1. Look at lead
uh,
1, 2, 3, AVF. What do you see? يعني do you see normal P waves ولا abnormal P
No.
waves؟ abnormal صح؟
Abnormal.
right?
mm,
فيعني in other words, this is not sinus tachycardia. Okay? So this is SVT that is because it's tachycardia, narrow complex, regular, but the P waves are not sinus in morphology, okay? So this is SVT, okay? So the P waves, in fact, are negative in lead 2 and 3 and AVF, okay? Okay, and flat in lead 1, okay? So this is SVT, okay? Um, but if you look more carefully, this is called, there is, SVT could be further classified into short RP and long RP, okay? Which just basically means the interval between the QRS and P is the definition that I mean, just to simplify things, if you see clearly P waves outside the QRS, this is called long RP, okay? So when you see long RP SVTs, this is the P wave, by the way. If you see long RPP waves, this might be, it has a specific differential, by the way, but this might be a sign that this patient might have recurrence of SVT frequently, might need combination therapy, might need IV medication initially. So this is just a type of SVT that is usually more difficult to treat. Ablation is probably more required. Okay. إذن عموما we have SVT protocol based on what I just said. We have SVT protocol that we did once in a while, يعني a while ago, but no one really looks at it, to be honest. But just to like we said, if you have SVT that is regular, reentrant, stable, most likely, you just do immediately terminate. Okay. طبعا you look at your SVT. If it's short RP, then you usually just beta blockers are good enough. Okay. Atenolol or propranolol. Okay. But if it's long RP, then you still wouldn't want to use beta blockers, but many people would start with flecainide. Okay. Because you probably would need more more potent drugs to control it better. Okay. But it's largely the same, exactly what I just said. Okay. Okay. Anyways, so now for regular SVTs, okay. For a regular SVTs, طبعا your main differential is atrial fibrillation, but this is rare in pediatrics. But otherwise, atrial tachycardia is the most frequently seen irregular SVT, which just means there's a focus in the atria somewhere that is firing at, different rates. Okay. It is usually more difficult to treat, and then it might be associated with cardiomyopathy, or it might result in cardiomyopathy. So in any way, you want to do echo for sure if you diagnose atrial tachycardia patient. So it's like we said, irregular. So this is an ECG of a patient with, as you can see, narrow complex tachycardia that is irregular. This is much. Heart rate here is faster than the heart rate here, and then it terminates, and then there's a sinus beat here, and then tachycardia resumes. So it's irregular, but obviously usually not a complex and so forth. Okay. Flutter might be irregular if there is variable conduction, but usually, like we said before, regular. And then really quick for flutter, if a baby presents with flutter, you just cardiovert and usually nothing happens. Nothing you need to do further. Okay. But if if the patient presented with flutter that is beyond neonatal period, then it's very often associated with cardiomyopathy or congenital heart disease. And then the patient most likely would require long-term medications and preferably need to ablation surgery. Okay. Obviously, before you cardiovert, you want to make sure there's no thrombi, and then once in a while you need to anticoagulate patients if they have multiple risk factors for thrombi. Okay, formation. Okay, so this should be, I think, case 3. So this is this is probably the last case. So this is a patient who presented with also 8 years, presented with tachycardia, but was very pale, and the heart is very rapid. Obviously, it's an ugly ECG. It's very rapid. It's irregular, but it's not narrow. It's wide complex. Wide complex polymorphic morphology. Obviously, when you encounter such a patient, doesn't look very well, you have to shock the patient. So the patient was shocked. But just before I continue, remember, so this patient presented with wide, irregular. Sometimes wide complex tachycardia is actually still supraventricular, but with aberrancy. But there is something that you need to know of. So WW patients are at risk of atrial fibrillation. Yes, we said it's rare in pediatrics, but WW patients especially are at higher risk for AFib development. And when you get AFib development, the atrial fibrillation might go down the accessory pathway and results in rapid ventricular rates. And thereafter, polymorphic, it presents like a ECG with a polymorphic VT. Okay, so the patient has very rapid ventricular rates, and then hence he or she is at risk of cardiac arrest. Okay, so sometimes white complex rhythms are also are supraventricular, and you have a specific differential. Okay, so SVT with aberrancy, tachycardia with aberrancy, AFib with WW is one differential. Okay, so like we said, irregular, polymorphic, and there is the onset of the QRS slurred, which suggests WW with AFib. Okay, anyways, so the patient was cardioverted, and this is the ECG post cardioversion. Actually, the rhythm just spontaneously changed without even cardioversion, and as you can see, there is short PR and delta wave, right? If you see very carefully, there's short PR and delta wave. Okay, obvious, guys? Yes. Okay. Yes or no, guys?
Yes, yes.
Yeah. Okay. It's not the easiest ECG, but يعني spontaneous termination of a irregular rhythm. Then thereafter, there's a short PR delta. So in retrospect, that ugly rhythm was AFib in WW, and then that results in bizarre ECG. Okay, this is called pre-excited atrial fibrillation, and this is why WW patients are treated differently, because they are at risk of such ECG. Okay. Okay. ف Okay. فطبعا so specifically for such patients, pre-excited atrial fibrillation, it's life-threatening. So this patient needs ablation almost urgently. So you cannot even discharge the patient. You probably should admit the patient and do the ablation during that inpatient stay. Okay. Sometimes if ablation is not possible for whatever reason, you want to give high-dose flecainide to protect the patient. Flecainide specifically, it slows down the accessory pathway conduction, and hence the patient gets more protection. Okay. And this patient underwent ablation, and then discharged from clinic. Okay. Okay. So in conclusion, I think first of all, I cannot stress this point that you want to do a ECG during your adenosine administration. Okay. And then adenosine is contraindicated in irregular rhythms, because, for example, in that pre-excited AFib, if you give adenosine, you might, first of all, you'll waste a little bit of time. Second of all, you might make the ventricular rate even faster, because you're just promoting more conduction down the accessory path. You're blocking the AV node, you're going down the accessory pathway more, and then you might worsen the patient status. Okay, so WW should be respected, and then should be referred to EP service, and ablation should be highly considered. Okay, otherwise you want to have an approach to how to approach an SVT case, and then like we said, this is our typical dosages that we do for everyone to be aware of. Okay. Okay. I will, before you have anyone has questions?
No, it's okay.
Okay, let me stop recording just a second. Where do okay, so here.